Our first speaker is someone that I believe you know pretty well. So Jonathon Jui is quite accomplished. We're happy to work with him here, but you'll also see him as far as being the lead with the Multnomah County EMS, as well as the disaster work that he does. And we're really happy to invite him here as our first speaker, talking about the emergency department management of acute stroke. So please join me in welcoming Dr. Jui.
Good morning. I have the opportunity to be up first, and for people that know you, I don't actually wake up until about 12 o'clock, so if I start slurring my speech or falling asleep, just lob a bomb at me and wake me up as well, okay? So this topic is not going to have a lot of fancy slides, but it really will give you an idea of the optimal response to stroke as well, and I'm going to be presenting 3 cases. One of them actually is my case about 3 weeks ago in the emergency department. In all these 3 cases, the stroke was sudden, it was identified and witnessed, and EMS responded on 2 of them, ED responded on 1 of them, and the results were stunning. They were high-grade strokes, and they had potentially lethal consequences, but they had timely interventions, and this is probably the best-case scenario outcome as well. The other caveat that I'm going to comment on is that in all these cases, the reason I'm presenting them is that there's a lot of controversy regarding the actual use of TPA and invasive therapy in strokes, and the real question is, where's the sweet spot? The sweet spot clearly is in the first 2 hours of stroke, ideally in the first hour, like we've taken lessons learned from STEMIs, and the earlier the better. So time is brain and time is muscle, so the 2 corollaries really do apply. So let's take this first case, and actually it's 3 cases here, and see if we can learn some lessons from those 3 cases as well, okay? The first case, you can actually see it. I was in the emergency department, actually minding my own business, seeing patients when one of the ED OBS instructors, nurse practitioners, comes up to me and says, "John, we were just wheeling this person out. She had a TIA. It was seen by stroke, resolved completely. We were going to just put her in the car, and all of a sudden she stopped talking and she couldn't move." I said, "You're kidding me?" I said, "No, that's really, I'm serious." He says, "Oh, bring her back." So you have an 82-year-old patient who was just seen in the ED, admitted to ED OBS with the eventual diagnosis of TIA, seen by the stroke team about 2 hours ago. She was being discharged and was being wheeled out to ED. He suddenly noticed a profound left-sided facial droop, left-sided weakness, upper arm and upper leg. She had underlying atrial fibrillation with known inadequate anticoagulation, and that's probably one of the things that will have the theme here. As you all know, stroke in our community is one of the highest in the nation, and about 80% of the strokes are thrombotic and embolic, and the other ones are basically thrombotic at the site as well. Okay, she is on Coumadin. Her INR was 1.4, which was low. Normally, like at 1.7, we're actually low 2s as far as, so she was inadequately coumadinized as well. Okay. On examination, pay attention to the highlighted in yellow. Everything is normal, with the exception of she had a profound left facial droop and left lower extremity and left upper extremity weakness, and she was unable to speak. So she was aphasic and unable to speak as well when she was wheeled back, which is about 3 minutes after the event occurred. We did have fortunate labs, and we were aware that her INR was 1.42 as well. So within basically 3 minutes, we decided she indeed had a sudden stroke and proceeded to obtain a CT scan of the head, which is our normal standard operating procedure. However, as you can see in this, these slide sessions here, there is a controversy whether we should get what we call regular CT scans or CTAs as well. And this has a lot to do with emergency department management, including contrast. I made a decision to get a CTA primarily because she had a TIA, and we didn't know what her anatomy was, as well as the possibility of high-grade stroke. And so what happened was, this is what really happened. So we actually had a CT and a CTA, and I was talking to the stroke fellow, and this is the conversation. Hi, I'm going to call you about acute stroke. Mrs. So-and-so was seen by you about 2 hours ago. She's got an acute stroke. Oh, it's probably just another TIA. So, gosh, it's really a true stroke, and she has a clot at the M1 distribution. Oh, I'll be right down as well, okay? So that is probably how the conversation went as well. So let's look at the times. So we in the emergency department like being the standard bearer, and I actually probably have the OHSU STEMI time, about 14 minutes door to opening of cath. And look at the time, this is stunning. Patient had the onset of stroke around 13:10. So she was wheeled back, had CTA ordered, and basically the stretcher almost never stopped rolling. She was rolled back and got a CTA, and all the labs were already in the chart. And at 13:15, 5 minutes later, the stroke team was at the bedside doing the stroke scale as well. Okay, at 13:23. Let me repeat this, 13 minutes after the stroke occurred, she received a TPA, okay? So the TPA was administered, and the conversation was like this. We can't give her TPA, we don't know what her creatinine is, and we don't know what her baseline INR. Look it in the chart, it's right in the chart. Oh, okay, as well. So if you could it's just like having a cardiac arrest at the airport or at a casino. Everything is in your favor as well. So everything was in this favor as well. So she actually got TPA. By the way, for people that EMS doesn't know, TPA is like VEC. It's a vial, and it takes about 5 to 10 minutes to mix it up. And so that's fortunately we have a pharmacist that does it as well. So she got TPA at around 13:40 hours, which is about 17 minutes later. She had a marked improvement, okay? The improvement was the point that she was able to start speaking. Her left arm started moving, and her left leg started moving. And about an hour afterward, she actually had almost complete resolution of symptoms as well. She started having a little bit of stuttering going back and forth, but about 2 hours after that, she was completely resolved. So honestly, when you look at this is a high-grade M1 stroke. If you let her, if she didn't have the stroke, she would have had a catastrophic outcome with residual left hemiparesis and left aphasia as well. Lessons learned, not all strokes are equal. If you have a fresh clot, this is very similar to the STEMI, you can do a lot, and thrombolytics are very effective, very effective. This is probably one of the best case outcomes regarding timing. You couldn't ask for a better timing and response from the stroke as well. The second thing it allows us to do is if you looked at the CTA, I'm going to show you some ideas about the circulation. It gave us an idea about where to go and what interventions to do. So it's sort of like cardiology. You can put the cath, you can put the stent in, but you may have to have other options as well. And so I think the science of interventional, i.e. the angio person putting the rotor or drainer pulling the clot out is basically very young. And in the next 5 to 10 years, we will see the real role and where, when, and how it will fit as well. Okay? So you can see here, she got TPA, and the only reason I'm putting this for the nurses that are there, it's 0.9 milligrams per kilogram, first 10% in the first bolus, and the remaining in the subsequent hours as well. How many people here are from rural Oregon as well? Okay, back in there. So if you actually see the Germans, and looking at the European literature, we follow the European stroke literature quite well. They actually have a mobile CT scan, so some very rural areas in Germany, wherever those may be, They roll them into the CT scan. If they have prolonged transport, the telestroke will actually roll them into the mobile CT scan, get the CT scans, read by the CT scan. Telestroke is interviewing them, and actually EMS is pushing the TPA as well. So in certain cases, in very specialized situations, EMS can actually administer the stroke protocol. We're doing this in rural Oregon now, in the rural hospitals, but not in the EMS setting as well. Okay. So what happened to this lady? As you can sort of see, she did very well. She went home almost completely intact, and she had a CT perfusion scan, which was essentially normal. So she had a very high-grade clot at the M1 distribution. I'll show you later where that is. And within hour or two after TPA was administered, the clot was resolved, and she had complete reperfusion as well. The other thing I need to give you an idea of what's going on here is we really do not know completely how brain cells die. There is some literature in the cardiac arrest literature suggesting that brain cells don't die of anoxic brain injury, they die of reperfusion brain injury. We do not know what time and what case and what scenario that reperfusion brain injury occurs as well. So in that setting, that is the next 5 to 10 years. So let me translate that. So what could happen is that when you restart the heart or do CPR, there's a certain threshold of that reperfusion injury occurs, anywhere from 5 to 10 minutes as well. We could be saying, okay, leave them as it is, don't do CPR, and when we do CPR, we're going to put them on a pump and do CPR completely as well. So the issue of reperfusion injury is the following. Let me restate that. What happens is the formal thinking was that the brain cells die from lack of oxygen, hypoxic brain injury. It turns out there is a significant component that the cells probably are intact in a quiescent, dormant state, but once you start having blood flow without oxygen, that actually causes the damage. Does everybody follow what I'm saying? There's a certain amount of time where that really occurs, but there is some data that's increasing that indeed a lot of the brain damage is reperfusion injury rather than hypoxic brain injury as well. Okay? And that's going to revolutionize our resuscitation management once we understand that concept. All right. So you can sort of read it, but basically the CTA with diffusion is normal as well. Okay? So we were just stunned on this time, and the ED and the stroke team really deserves a round of applause. I know you can't see this, but what you actually see from the EMS point of view is that this is almost like crew resource management for the emergency department as well. You can see the top part here, that's the nurses. And if you notice, the 99% of the heavy lifting is done by nurses as well. Okay, it's like many things in medicine. I'm looking at Fred right now. This is the doctor portion here, and this is the stroke team portion as well. If you actually go in granular, and the real reason I'm saying this is that if you're actually witness a stroke in EMS, you're doing 99% of this, okay? So the EMS can actually do all the heavy lifting in the field in the first 10 or 15 minutes. If you go through that, let's see what they do. Rapid identification, yeah, you can't move his arm. Chief complaint, can't move his arm, can't talk. Stroke scale, IV, O2, monitor, CT scan, we don't have that yet. Rapid response, that's us. Social worker, we don't have that yet. Laboratories, we don't have that yet, but there's a Chem 8 here. EKG we have, and all the other stuff as well, and obviously you don't have imaging as well. But so if you take a look at the list, the key components of the list is about 95% EMS does as well. So you're going to see in the next two cases the patient well packaged and well processed going through. The emergency physician obviously is here primarily to confirm or identify what we call the mimickers of stroke. And in particular, that's why we actually moved to the LA stroke score. So the highest, I would say, false stroke activations, unlike STEMIs, is in the settings of post-seizure Todd's paralysis. So let me slow down here. So if you have a seizure that's not well witnessed, you get a hemiparesis and sometimes aphasia as well. For many of our patients, I mean, if I work on a Friday, Saturday, Sunday night speaking to the choir, I can't speak to half of my patients that come to the emergency department as well. So that's our normal modus operandi as well. So if you happen to have a seizure or found somebody down, that there is a high percentage of them that will have what we call Todd's paralysis, and that will mimic a stroke. Occasionally, we will see patients with hypoglycemia that actually mimics a stroke as well, and occasionally we'll have conversion disorders that will mimic a stroke, which is usually a rule-out diagnosis. So disposition, depending on what we actually have, the standard of care, if you're TIA and resolved, you go to our ED OBS, the neuro ICU, or other stroke interventions as well. A quick word on our TIA intervention. There's two issues on TIA, and this is for your background activity of your knowledge bank. It turns out if you actually have a true TIA, that's a harbinger of, I would say, impending stroke. That's like crescendo angina. So a TIA is called transient ischemic attack, and it's usually manifested by either a transient problem with vision, aphasia, or transient motor weaknesses that actually that completely resolve within a 24-hour period. Okay, so a TIA is transient ischemic attack, and most of the time these are secondary to thrombotic events or occlusive events from the carotid arteries as well. These are not usually events from the heart, which is atrial fibrillation, but these are carotid artery atherosclerotic plaques that actually flip off and cause a transient clot in the brain as well. So our objective in the emergency department for evaluation of TIA is to determine, number one, if they had a stroke, number two, if there are risks at further TIAs, and we almost all the time are very careful getting the usual labs and chemistry, depending upon what imaging study, at a minimum a CT non-enhanced, and then we end up doing carotid ultrasounds for severely stenotic carotid disease, and if indicated, a cardiac echo. By the way, how many here have actually seen a stroke in a young person? Okay. So a lot of times in a young person, there's actually only two real variables. So strokes do occur in a young person. They occur in the setting of a congenital heart disease, or more importantly, there's a syndrome called patent foramen ovale, PFO, okay? And that's where there's a hole in the atrium of the heart, and you can get a right to left shunt, and occasionally you get a clot. So if you have a young person who actually acts and behaves like a stroke, treat them like a stroke as well, and because it does occur, or even though it's rare. The second times that it occurs is that you have congenital heart disease and you have abnormalities. So strokes in young people do occur, but they're rare, but they do occur. Take them seriously. Okay. Let me talk a little bit about TPA. And TPA, and the real reason I know most of you are EMS providers here, but there are some exclusion of TPA. So if you see the patient roll into the hospital and you think they're a good stroke candidate, there are some caveats about when to where we give TPA. So the first lesson is, and some of the issue here is that there is a vital signs within the NIH guidelines that requires that to patients who are having an acute stroke, that their blood pressure needs to be less than 185 systolic and less than 110 diastolic. So you're going to see patients actually in intrahospital transport who are on either labetalol or nicardipine drip as well, with antihypertensive as well. So this is one of the parameters of giving a stroke. We need to bring their pressure down to the point of treatable diseases as well. The rest of that is sort of intuitively obvious when you actually look at it. Previous intracranial hemorrhage, recent surgery, you can sort of read it. The other one that you actually can see, if you have a CT or CTA that shows a massive stroke, that's a relative contraindication for TPA. So massive is usually more than one lobe. Most of our strokes are one side. You have multi-side system that catastrophic disease. And they're usually with comatose, unconscious, unresponsive, with a lot of paralysis. That is a high-grade stroke, and probably a contraindication for TPA as well. Finally, as seen in the evidence in the first case, an INR or patient that's currently on anticoagulation is a contraindication, relative contraindication to a stroke. This actually causes us problems as well. If you have a patient who has a low platelet count, that is a relative contraindication. So ironically, the CBC and the platelet count actually slows us down as well. The rest you can actually read. They're sort of intuitively obvious. I won't dwell on that as well. Okay. So here is this is judgment area, severe stroke, age greater than 80 years. It turns out that my individual in the one was 81. And by the way, she was a Multnomah County EMS, she was a Multnomah County administrator. She told me that after she was able to talk as well. Oral anticoagulation, et cetera, et cetera. Okay. Also, you're going to see something that in the upcoming one of the problems I have actually is I work in a level 1 neuro stroke center. So I see technologies and verbiages that some of the other community hospitals see. So people that know me when I'm at the treatment protocol committee is I see a different level of care and I actually can see what the other community hospitals see. We're using a lot of different imaging tools, and one of the imaging tools that we actually use is heavy CTA. Actually, most of our community in the community stroke centers are using CTA as well. So there's a current controversy. The controversy to the people in the audience is that the routine CT, the primary motivation is to rule out hemorrhage. On the other hand, because our stroke therapy is getting so good, we would like to know where the anatomy is, and so the problem here is that the CTA is very good about identifying the anatomy, okay? So CT non-contrast is only 61%. If you actually are looking for the stroke, it's only 61% positive. So let me sort of slow down here. If you're looking for the stroke to appear on a routine non-enhanced CT, we only see evidence of a stroke 6 out of the 10 times. Very early, you're not going to see anything as well. It's sort of like the STEMI or the troponin rising. There's a delay in the response time as well. On the other hand, if you actually look at the CTA, and the CTA, depending upon how your imagers is, the issue here is 92 to 100%, depending upon how good your CT scan and how good your neuroradiologist is. Our center is really good, and if you have a 64-bit slice, very high-power CTA, it's really, really good. So on most strokes, if you're really in doubt about what's really happening, the CTA can give you some very valuable information, and I'll expand on that a little bit later. So in difficult strokes, I end up getting a CTA as evidenced by my first case here as well. Okay? So here, this is something that you probably don't know and have not seen, and frankly, I had to refresh this area as well. Not all arteries in the brain are equal, okay? So let me repeat that. Not all arteries in the brain are equal. So what you actually have here is the takeoff from the carotid artery. This is the coronal section, as you can sort of see. This is the M1 distribution. This is the M2, and this is the M3. It turns out that the M1 has the big clot. That's intuitively obvious. It is the M1 that's a problem as far as a clot and the ability for TPA to lyse the clot. So if the clot's big and it's old, the TPA may not work. If you have a clot in the M2 and M3 distribution, most of the time the amount of TPA that's required will lyse that small amount of clot. Am I making sense to you? Okay? So this thing actually has two things. Number one, if you have the location of the clot, you'll know approximately how difficult it is for your TPA to work. Not all TPA works. So if you actually look at the literature, TPA only works on an M1 distribution about 60% of the time. That's the problem that occurs there as well. It works fairly well in M2 and M3 as far as that's concerned. If you look at the stroke literature, they don't really distinguish between the location of the clot, and I'll expand on that a little bit later. Am I making sense to you guys? Okay. Let's look at case 2, which is really, the last two cases are EMS cases. So this case is actually happened about 2 or 3 weeks ago. Lady drove himself to a Red Robin restaurant. This is on I-205 and I-84. Very close to the Adventist, by the way. She went inside to order her lunch. She was seated at a table in the booth, and she was witnessed by a waitress to have a 1-minute syncopal episode. This came in as a UN3, okay? The patient woke up and was unable to speak. Waitress called 911, which is great. Patient was attempting to speak on our arrival. This, by the way, this is verbatim from the AMR chart. She was having a difficult time choosing the right word, and her speech was slurred and jumbled. At times she could understand, at other times she could not understand. She complained of a headache and said she couldn't walk. She would sometimes follow commands, at other times seem confused. She continued her symptoms into the entire contact of her EMS chart. Her symptoms included right arm and right leg weakness, absent grip on the right, and positive peroneal drift on the right as well. Good triage by fire and EMS. If you look at the call time at the scene, call received 04. EMS was quick. Time at the scene 08. 4-minute response time at patient's side 010 here as well. So time transporting 10 minutes at 10 or 11 minutes at the side. Transport time 2 minutes or 3 minutes to Adventist. Adventist, she gets wheeled straight into the CT scan. CT scan confirms no hemorrhage. She gets TPA and complete resolution of her symptoms as well, okay? So I don't have her NIH stroke score, but it was going to be higher, greater than 12 or 14. But we got a call from TPA, and they were stunned how quickly she responded. And this is very similar to what happened. So here we have, again, a witness stroke, rapid response time, rapid assessment, rapid transport, rapid activation. ED was right on top of it. Timely TPA and complete resolution within probably 45 minutes to an hour after her stroke. Does that make sense to you? So this is almost, it's unbelievable, because this stroke could have been catastrophic as well, okay? So she did have atrial fibrillation, probably through a big stroke, and what really happened, okay? And that's what really happened. So you actually can see here, I don't want to bury, but she had a slightly high blood pressure. She had a stroke score. Her Glasgow coma score was 14. And she continued to have slightly elevated blood pressure. And this is really one of the problems that we will have in the transport and care is monitoring the blood pressure, okay, as well. Okay, let's move on to case 3. This happened about a week ago, or actually 4 or 5 days ago. Patient was on a golfing range, which is in southeast Portland by Reed College, with a friend when someone became unresponsive. Friend says he was hitting golf balls and went down and sat down and squeezing his hand, not responding to hers. He was then found slumped over the bench on the ground, breathing normally but still not responding. Came in as a UN3, I believe. Upon arrival, patient was lying supine on the ground, and Portland Fire, Engine 20, was at the scene assessing him. He would open his eye to verbal response and apparently follow commands, but not verbally respond. On the scene, he appeared to be moving his extremities of the left better than right. He did move his right arm when the IV was started, but could not squeeze with that hand. He was lifted to the gurney and transported to Code 3 University Hospital for possible stroke. En route, he continued to move his left side, and there was no voluntary movement on his right side. He continued to open his eyes, but you could say his name and spoken, but appeared he wanted to speak but could not. So this is a motor Broca's aphasia, okay? And we just sighed heavily instead. Upon arrival to the hospital, he's opened his eyes more than on his own, but remained to have no voluntary movement on his right side. He did have an active reflex on his right foot. This is all verbatim. So EMS charted basically right arm weakness, some right arm paralysis, and some left arm weakness as well. Okay, let's look at the times. Here you get dispatched at 1300 hours, en route 1301, at scene 1307, at patient size within 2 minutes, time transporting 10 minutes, time transport completed approximately 10 minutes later, okay? Very, very, very quick response time. So he got to the hospital within the half an hour after the onset of stroke. This is also amazingly well. So what happens here, you saw the glucose was done, vital signs you see, Glasgow coma score, stroke scale was performed. EKG was performed, vital signs, and Glasgow coma scores. This requires a team effort, requiring both fire and EMS. This is really, fire and EMS did a really good job on this as well. Okay, ED history and physical, a lot of this repetition, but basically he has sudden of aphasia, syncopal, right-sided paralysis, and the rest of you actually have read as well. Here you notice his blood pressure was 209/89 is aphasic, not following commands, very similar to what EMS reported as well. His NIH stroke score was 21. Okay, so many of you don't know this, but 21 is catastrophic. It is very high, and this is about an 80 or 90% mortality rate, depending upon what stories you have here. He had a very heavy right hemiparesis, left gaze, and moderate expressive aphasia here as well. So he had a CTA and a CT, and you had a cutoff at the left M2 branch, which is a high-grade cutoff, a left middle cerebral artery as well. He also had an occlusion of the right internal carotid artery with collateral flow. So he had both arteries on his right and his left side as well with collateral flow as well. So let's look at what happened in ED. So after a neuro exam, stroke team responded within 5 minutes. A stroke team immediately came to the bedside. His blood pressure was controlled with labetalol, push 10 milligrams. TPA was started at 1:14, about probably around 20 or 30 minutes after he arrived here as well. This is fairly rapid, and you can see the dosing here as well. So here you have a CTA diffusion scan where there's a mismatch. So one of the things that we are doing at the OHSU is we're doing a perfusion mismatch. So what really it says is the perfusion mismatch is areas that are ischemic but not dead. That is a special kind of CTA that we're actually doing routinely. If you have dead tissue that's dead tissue, then that sort of weighs against TPA. But if you had ischemic tissue that is not dead yet, then you actually have good reason to give TPA as well. Does that make sense to you guys? Okay. So we actually have TPA was given, finished infusion at 14:58. He went under a diagnostic angiogram. It was decided not to do interventional radiology to get the stroke, get the rest of the clot, and he was transferred to the ICU. Okay. If you look at the discharge summary, you can't really read it here, and I'm going to move on to this here. Right here. This is what happened. The patient resolved very well. He had moderate aphasia, but had full movement of his right and left or upper arms. A lot of the aphasia is going to resolve as well. So you've gone from a near catastrophic stroke to a fairly functional individual that is able to move and probably end up talking as well. And this is probably also stunning given the high NIH stroke scale as well. What was the key to this gentleman's survival? The key was immediate recognition, rapid response, as well as TPA and rapid assessment of what was going on here. Any questions here? So if you look at the 3 cases here, you can actually see what did they have all in common. They had immediate recognition. Part of our problem with stroke is that we're getting the stroke later. They wake up and they have a stroke. They don't know when they had a stroke, and so one of the problems we have in our diagnostic is the timing of the stroke as well. The second one is TPA is very effective. It is most effective in the first 2 hours, maybe up to 3 hours as well. And third one is that this requires a team effort, almost crew resource management, to the point that you can actually move the patient off, divide and conquer, and he got rapidly resuscitated by both the EMS team as well as the ED team and the stroke team, all combined, working very well. We never used to see this coordination until recently as well. It took us a little while in the STEMI, right? It took us a couple of years before we got our pattern down, and I think we're doing a very good job on our STEMIs and our cardiac arrest now as well. Okay? So in conclusion, what do we know? There is compelling evidence that TPA and other interventions performed early, ideally in the first 2 hours of the stroke, does really make a difference. Stroke is much more complicated than what you read in the literature. What we actually see here is that depending upon where it is in the diffusion, the time of onset, as well as the location of the stroke, individual modalities will be selected as well. We do not know. It's really simplistic in saying that interventional radiology does not work. It may not work in a proper setting. I'm going to end on a sort of a research note as well. Number 3, greater use of CTA, I can tell you in the emergency department, is going to be enhanced. An initial assessment of stroke is coming down the pike. In fact, talking to my colleagues at Emmanuel, Adventist, and Providence, they're using CTA very frequently, if not almost all the time as well. Some evidence on greater efficacy of combination, TPA with invasive therapy, which I'll present to you in a second here. What we don't know is the role of induced hypothermia and some of the other brain-saving modalities which are coming down the pike in the next 4 or 5 years. There is a NIH-sponsored hypothermia study for stroke that's currently underway as well. Okay, so let's. How many of you are actually aware of the New England Journal article that actually was published last month or 2 months ago, suggesting that there was no difference between TPA and interventional radiology? That actually sort of not really stunned us, but it actually set us back for a little while. So I'm going to give you a teaser. Okay. And the teaser, the word's not done yet here. This study was just published, I think, in the journal JAMA Neurology, IVTPA with endovascular therapy with no treatment with intracranial volume occlusions. So a newly reported retrospective study by Dr. Guto et al. Compared IVTPA with endovascular therapy with no treatment in patients with intracranial large volume occlusions using a novel strategy for measuring final infarct volumes. This was a one-center study at Grady and Emory. All patients included analysis within 6 hours of stroke. And what they found was that in patients with anterior circulation, large vessel occlusions, median infarct volume was significantly smaller, but those treated with intra-arterial therapy, intra-arterial therapy than those treated with either IV, TPA, or no perfusion as well. And when patients were stratified based upon NIH stroke scale, endovascular intervention was clearly superior to IV TPA or no treatment in patients with stroke score of 14 or higher as well. Okay? So the bottom line here is not to make you stroke expert. The bottom line here is to don't believe all the verbiage and adage of what you're actually seeing in the literature. The word is not out yet. And I think invasive therapy has a role, but it has a role that needs to be well defined in the next 3 to 5 years as well. Make sense to you guys? Okay. So in summary here, there is some evidence that for high-grade obstructions, that TPA in combination with endovascular therapy, and when I'm talking about endovascular therapy, I'm talking about getting the clot out with a clot retrieval system that you're going to hear about, like the Mercy system or the Swift system as well. Okay. I think we're close. How am I doing as far as time?
We've got some time for questions.
Good time for questions.
Yes.
Okay. Questions? Damien.
Right, so the CTA biggest risk, is it kidney function that you're most concerned with?
Yes, there's actually 2 problems with CTA. The first problem with CTA is the kidney function, and what was buried in there is that we're doing a M.P.H, which is a point-of-care iStat, and that has actually markedly improved our stroke response time. Keep that in mind, because we could be doing that in the field. It is a field, it's a complex CLIA, but it's entirely possible we could be doing some of that in the field. The second problem with using contrast is contrast allergy. It turns out this lady here, she was aphasic, couldn't tell me about the allergy. So we gave we gave the contrast. I get this urgent call from the CAT scan. It says, by the way, we gave the contrast. She's allergic to contrast, but she's fine as well. So a lot of patients who are contrast allergies just do just fine as well. Did I answer your question as well? So that's the only problem with contrast. Question up there.
You mentioned therapeutics.
Yes.
In what setting would you be doing that? Would you be doing that after you busted the clot, or would you start that before?
Yeah, the question of hypothermia, I can't really answer that question because that's currently underway as well. But a patient, it's entirely conceivable that patients with obvious severe hemiparesis, with patients who can't speak, can't move their right arm, are patients who are candidate for hypothermia. So many of you know that we're carrying cold saline in at least Multnomah County as well, and that could be the same. It's not illogical to assume that the induced hypothermia that saves the brain on the cardiac arrest would work in the stroke as well, but that study has not been done. So high-grade strokes would be my answer to that, but I'm just speculating right now. There's no data on that area as well. Question, Jeff?
When you're looking at the CTAs, you're trying to distinguish between ischemia versus actual dead tissue.
Mm-hmm. Oh yeah, the reason I didn't put that out because I anticipated that the stroke team is going to show some of those pictures later on, so I didn't really want to redo that. You're going to see that area. It's stunning when you see it, and that's a modality that we've been using at least 18 or 24 months here, and it's going to be almost commonplace in especially late strokes where you actually have a fairly formed clot and you have to determine whether I'm going to give TPA or I'm going to go after it or it's fruitless to actually flail. Does that make sense? So I think there is some imaging modalities as well as that we can actually determine what modality to choose, and it requires some advanced imaging techniques that fortunately is at the level 1 as well. But I think if you actually look at it, I think EMS, especially early recognition, and perhaps in the rural setting, even early intervention, depending upon where you're at, could be as well. To the AMR crews here, you need to be up on your stroke because we're going to get transfers as well. We're seeing transfers occur, and they've occurred in the last month. We're getting 1 or 2 transfers a month from other stroke centers to major stroke centers as well. So you'll be taking care of these stroke centers. You're going to be seeing 2 things on your EMS. One of them is the TPA, and frankly, it's either stop it or not stop it. The other major thing that you're going to have to do something about is the hypertension. And frankly, I actually like nocardiapine, but I start with labetalol depending on how bad they are as well. So you're going to be, EMS is going to have to learn 2 new drugs. One of them is labetalol and the other one is nocardiapine because you're going to be seeing a lot of that on your transfer cases as well. Question?
Another question about the CTA. If you're able to discern what's ischemic but still alive, does that help resolve some of the problems with having an unknown, last known normal time?
Yes, that's right. The question was if you're able to determine ischemic still alive or dead, will that resolve the decision? The answer is yes. It really aids the decision-making capability. It also aids somewhat in the timing of the stroke, because we learned a lot from the STEMIs. If you actually look at the STEMIs, just to reiterate what I believe you really know, within the first hour of a STEMI, if you actually have an acute witness STEMI, the clot is relatively not organized. And by not organized, it's sort of like Jell-O. You can actually mish it around, it'll fall apart as well. Once it passes an hour to hour 90 minutes, you'll see the fibrinous white portion. You'll see clot if you actually pull it apart as well, and you'll see clot formation as well. That clot is much harder to take out because the fibrin is already formed. So not all clot is the same. Early clot is much more dissolvable than late clot. Early clot's red clot, and late clot's white clot. The point I want to make is that the ischemic portion may be propagation of the clot. Does that make sense to you? And continued propagation, and that's what TPA and heparin really do. Good question. Go ahead.
And do all the primary stroke centers in the area here have CTA capability?
Yes, they are. Do all primary stroke centers have TPA capability? Yes, they are. I'm not up to snuff. Anybody from Clackamas County here as well? So this is where I'm at. Washington County, Multnomah County, all hospitals are stroke centers. Could you give me an update on where we are in Clackamas County? Is Willamette Falls and Milwaukee stroke centers as well? No. Okay, I don't believe they are, but I don't want to misspeak myself as well. So I think Clackamas County is, only Kaiser is the stroke center that I'm aware of as well. But that makes sense. Question back there.
Is there anything we should be doing pre-hospital to help facilitate those CTAs more promptly as far as like IV access, like location, size, all of that?
Yes, that's a good question. The question is there any other, so you're at a point where we really need to fine tune outside of crew resource management. The second, so the quick answer to the problem is the following, and we haven't figured this out yet completely, but the second IV, you need an 18 gauge IV to do a CTA, okay? You also need another 18 gauge, you'll need a second IV if you want to give a labetalol drip or something else like that. So when you give TPA in an infusion, that sort of takes your only IV. So starting a second IV is highly recommended if you have a long transport time. The second, 2 or 3 other barriers that occur is the blood. We haven't figured out, we normally toss the blood, but I know Washington County is not tossing blood as much as well. So, and the third one is patient registration as well, that helps as well. So 3 things. Number 1, obviously starting a second IV. The second one is getting an EKG, because that's something you need to get, as you saw there. And the third one is actually getting the blood, and the fourth one is actually getting them into the system. These are purely operational issues. But I think that's a barrier. So what I didn't say to you is we have time is muscle and time is brain. So every 30 minutes, the mortality goes up, mortality and morbidity goes up 10%. So this really is, the time is ticking. The problem with all the studies, it lumps everybody that's under 3 hours into one group, under 6 hours into another group. That's really not a great way to look at outcomes. You saw these were not selected. They were just stunning where how quickly EMS and the ED reacted to these 3 cases. This is like the best case scenario. Remember I would say in 2000, around 2000, there was a Dr. Venezuela published a casino study where everything was monitored and they could actually know when the person went down. And they got defibrillation within 3 minutes or 4 minutes after they went down. That's better than any hospital. So it depends on where you're at. If you have your stroke in front of the emergency department, that's probably a great place to have it, or right in front of a golf course in front of EMS, fire and EMS station. Like Alberto Salazar, right? He collapsed right in front of, what station was that, Mark? He was just one lucky dude as well. So that is there's some fate to our work here as well. Any other questions? Thank you for your patience.
Did you have a question?
Yep.
No, I just wanted to say that Willamette Falls does have CTA capabilities. We do have to transfer those patients out. I work in the ED there, and
Yes. I'm not disparaging because I know Lisa in the group really you guys are going to go for a stroke center. I'm sure of that. It's just a matter of paperwork.
We have the remote access with the computer that we can do conferencing with the stroke doctors directly in the room, but we have to transfer those patients.
Yeah, I actually anticipate that you're going to be a stroke center depending upon where the paperwork is, as well as Providence, Milwaukee too. Thank you, by the way.